The following presentation is titled All About the Fog, Prevention and Treatment of Delirium in Hospitalized Geriatric Patients, presented by Group 3. This slide provides an abstract discussing the background of delirium, providing you with a definition, as well as reasonings as to why delirium can happen in older adults. The significance of delirium in the hospitalized patient, especially in the fact that it does cause serious complications and is oftentimes preventable. Here we have a snapshot of reviewed literature focused on the diagnosis, treatment, and prevention of delirium, as well as recommendations in accordance with best practice. While doing our research, our group did find that all patients are at risk of developing delirium. However, older adults are at a higher risk, and some of the causes of delirium are listed on the right-hand side of the slide. But I would like to point out a few that are prominent culprits in older adults, one being an electrolyte imbalance, and the second being an infection such as a UTI. And everyone knows no one swings harder than a granny with a UTI. Much like all conditions and illnesses, there are risk factors that put a patient at higher risk for delirium. Risk factors of older adults are present simply due to age and the natural body aging changes that happen, some of those being a reduction in brain function, vision and hearing changes, as well as past episodes. The more times a patient experiences delirium, the more likely they are to develop it again. This slide discusses the complications that come from delirium. This is much like Newton's law of motion. If you are in good health and experience delirium, you are more likely to recover and make a full recovery. However, if you are in an overall poor state of health and develop delirium, there is a higher risk that you are not going to recover even back to the health state you were in prior to developing delirium. And that can create huge complications if you've had a major surgery or if you were taking care of yourself previously, that can change your entire living situation. So this slide is just a few fun facts that the group and I found while doing our research. Just to kind of put it into perspective for you guys, more than 7 million hospitalized Americans suffer from delirium each year. Just imagine that those 7 million are in fact all ICU patients. Fun fact is that a third of cases of ICU delirium can be prevented. So a third of 7 million is 2,333,333.3333333 patients. That is a huge number. The most important thing for any profession is knowing the tools you have at your disposal to perform your job. And this slide provides us with a few tools available to assess delirium. However, the biggest one I have found and our research found is a simple assessment, the basic assessment, and not just once per shift, but frequently assessing your patient to document changes in their mental status and to make sure that you're recording these episodes of confusion or frustrations, things like that, so the next shift can compare notes and you can compare notes from day to day. So that those changes don't go undocumented and unnoticed. Best practice recommendations to correcting delirium is to use non-pharmacological therapies before resorting to pharmacological. So if you have exhausted all non-pharmacological therapies to reorient and reduce the delirium in your patient, absolutely use the pharmacological because you want safety for both yourself and the patient. But we could all take a play out of Bob the Builder's playbook and use those non-pharmacological therapies prior to asking for the pharmaceutical things to fix delirium. When looking at the impact of delirium on nursing practice, we need to reference back to that fun fact slide and look at 7 million patients experience delirium each year. That is 3.5 million patients that are older adults. That is a lot, and it wears and tears on nurses. It means a lot more bed alarms are being heard, call lights are being pressed, patients are at higher risk for falls, prolonged hospital stays. There are just so many that are affected by delirium that a nurse who's been practicing for any amount of time has experienced the burnout that comes with the complications of delirium. As cliche as it may sound, the prevention of delirium really does start with the nurse. Recognizing delirium early allows providers and nurses the opportunity to correct it sooner. Also, understanding the differences between delirium and dementia. Just because a patient is confused and older doesn't automatically mean that they have dementia. It could just be that rapid onset of confusion, which would be delirium. Also, utilizing non-pharmacological interventions prior to the delirium becoming bad or worse will help lessen its effects. Many of the ways that nurses are expected to perform in the treatment of delirium seem like a fairy tale in real world. Engaging with the family for reorientation and emotional support for the patient sounds great, but oftentimes families are not available to provide that to your patient. Identifying and treating underlying causes such as monitoring labs or medications, checking for interactions between medications or cause and effect. If a patient takes a specific medication, that may jumpstart a delirium episode. That can be really hard to monitor. So delegating what you can and is appropriate is definitely an aspect of treatment that nurses can utilize when available, but definitely a hard concept to fulfill. Advocates and educators, that is exactly what a nurse is. And to have a long-term goal for delirium and nurse advocacy in terms of delirium, nurses are going to have to focus on hospital delirium prevention protocols and quality improvement initiatives, as well as education for staff, patients, and families to be able to see the early signs of delirium to make staff aware. In conclusion, delirium is both treatable and preventable with early detection, and that early detection comes from adequate assessments by nurses. Those assessments will ultimately lead to reduction in complications and improvement in patient outcome and delivering high quality care to hospitalized older adults. We want to thank everyone for listening to and reading through our presentation. We hope that you guys have learned something. And again, thanks for watching.